Good morning, everyone. Welcome to another episode here at Just Podiatry. Friday morning, 3:05. Let's roll. Young gentleman who has presented to our office several weeks ago, severe pain to the right ankle, of unknown etiology. What does that mean? Of unknown reason. We decided to send the patient for an MRI, which revealed severe advanced osteoarthritic changes. A lot of degenerative joint disease inside the ankle joint as well as the subtalar joint. Two very important joints in our lower extremities. Let's go back to, again, Anatomy 101. Ankle joint made up of three bones: tibia, fibula, talus. The joint underneath is made up of the talus, right? The talus and the calcaneus. In there's something called the subtalar joint. There's something also called the sinus tarsi. Kind of like a little tunnel, right? Between this bone, the talus, and the calcaneus. So he has a lot of arthritic changes. Arthritis equals inflammation, which equals pain. So today, we already demarcated the areas of the injection. We're going to try a little cortisone shot first. We did speak to the patient about PRP, and we actually even spoke to the patient about adipose-derived stem cell therapy. So what that means is we'll start with the cortisone as sort of like a band-aid. The patient clearly understands that it's kind of like a hit or miss. Number two, PRP, the platelet-rich plasma, works really well. But at the top of the list for something like this, a lot of our professional athletes that come here a lot for this is the adipose-derived stem cell therapy, where we actually do a little lipoaspiration, right? Stem cells live in two places, one of them being the fat and one of them being the bone marrow. And sometimes we do these injections to really maximize their improvement. It's kind of like the Rolls Royce of the regenerative type of injections. But we're not going to go ahead and talk about that. We're going to go ahead and perform the what we call the arthrocentesis, the ankle joint injection, as well as the subtalar joint injections, with the hopes that this will improve the patient's discomfort. We've already demarcated the area. Let me bring this down because the patient's name is there. Our ultrasound right here, always our best friend. We've already demarcated the area, so without further ado, let's do this. Okay. So again, just like that, cold spray. I always tell the patient they'll feel a little stick. Okay, let's get a good shot there for all of our viewers. And right there, pinch all the way in. And now we infiltrate. Patient will maybe feel a little bit burning, maybe a little bit of pressure. That's number one. Numero uno. Numero dos. We're going now into the subtalar joint. You see how it's a little bit lower than this one? Right? Because it is. The joint is underneath the ankle joint. There's two ways. A lot of people just go in this way. Some people go in this way. Some people go in this way. Okay? But like I said before, you know exactly when. Bring the foot down a little bit. Sometimes you got to do this, but it's. And because of what's happening right now is right there. The problem is that he has so much arthritis, right? There's a lot of joint space thinning, and everything is on bone on bone. When there's cartilage, there's a space. He has no joint space. So you're trying to put a little needle into a joint, a joint that has no space. Okay? So what we did today, quick recap: injected the ankle joint, injected the subtalar joint with a little cortisone, more for what I like to call acute pain management. It's a hit or miss. Let's see how he does in the next couple weeks. He'll come back in 3 weeks and we'll reevaluate his condition. Right now he's hovering at about a 4 or 5 out of 10 in pain. I'm hoping that if we can get to 2, that's how I define success. Have a wonderful weekend.